Not long ago, Lindsay Brown wasn't sure she could continue playing the sport she loves.
Oh man, you're hot now.
Button.
Warren Henderson couldn't dress himself.
Okay.
Sharon Bossy didn't trust her grip on a cup of coffee. And Linda Holland couldn't use her left thumb for anything at all.
If you don't have a thumb, all you have is a fin, essentially. I could hold things with my hand, I could push them back and forth, but I couldn't hold them with thumb and fingers to get a grip on anything.
Whether the damage happened through injury, genetics, or just wear and tear, all of these people needed help to recapture their former quality of life.
I'm right-handed, and I can't eat with my right hand. I can't shave with my right hand. I can't comb my hair with my right hand. And then it's limited to the distance it'll move this way, and it won't straighten all the way out. It will straighten only this far.
For Warren, Lindsay, Sharon, and Linda, surgery was the solution. Each had a different physician, but those doctors are all part of the hand and microsurgery team at UW Medicine.
It's a consortium of surgeons who have had special training in hand surgery from various backgrounds, and half of us are from a plastic surgery background, half of us are from an orthopedic background, some of us have done special training in microvascular surgery, and all of us on this particular team do replantation and microvascular surgery. So we all share in the call, we all share in our special interest, and we all make sure that we cover each other in our various interests.
I usually take out the trapezium.
These hand team surgeons practice at Harborview Medical Center and the University of Washington Medical Center. Warren Henderson found himself at Harborview after a car pulled in front of his motorcycle, sending him into a frightening crash. He remembers the accident clearly, including the loss of his new leather jacket.
It was lucky that I wasn't killed in it. But the other interesting thing is, I was wearing a helmet, of course, because we have to, but I didn't hit my head. And so I was conscious during the whole thing. And I remember telling the aid car people when they picked me up, "Don't cut my jacket off. Don't cut my jacket." And of course they did.
You'll have to put up with my tying.
Okay.
Orthopedic trauma surgeons repaired the damage, but over the next few months, bone spurs developed in Warren's elbow.
That's the best I can do.
Well, I guess I can't complain then, can I?
Any time that we have a musculoskeletal injury, there's bleeding, and that bleeding becomes a clot. Within that clot are cells that are called pluripotential cells. And given the information in the environment, that will either choose to become bone, or it can choose to become fibrous scar. If it is surrounded or immediately adjacent to an area with very, very high blood supply, such as the knee and the elbow, lesser degree the hip and the shoulder, the information can come to those pluripotential cells and says, you know, you look like you really want to be bone because of the fracture surface of the bones that were repaired. And it's just like the hinge on a door. So if I put a stop on a door, it can only open so much because of the stop. And our whole surgery was designed to take the stops out of the hinge.
Besides his stiff elbow, Warren lost feeling in two of his fingers and part of his forearm due to a damaged nerve.
Since I can't feel it, what happens is that, see, it'll hit both of them, and sometimes it hits, when I want to hit E, it hits F.
After his surgery, Warren hopes to be able to accomplish the basics of life by himself again, like combing his hair, brushing his teeth, and getting dressed. He's also concerned about getting a new motorcycle. After all, he's been riding one for 30 years.
I'd like to be able to regain the strength that is in the right hand. And the reason for that is that when you ride a motorcycle, your throttle is on the right.
And so Warren returned to Harborview for surgery with Dr. Doug Hanel.
I want to stay there because they have the expertise that will be able to correct this problem better than any of the other facilities that we have here in the state of Washington.
We're actually trimming and cutting the bone and removing parts of the bone that are keeping the elbow joint from bending. And we're reconstructing the anatomy that was the normal anatomy so that the elbow joint could work.
In concept, it's a simple operation. In practice, it's actually quite difficult. Few doctors care to perform it.
I think we're going to go after the capsular here and the capsular scar first.
Okay.
Then we'll go after the bone right here. The reason that this is a procedure that isn't done by very many people is that it's not terribly easy. You're dealing with scar structures. You have to dissect through scars. You don't get to use a tourniquet. And the reason we don't use a tourniquet is that it allows us to identify the bleeding structures or the potential bleeding structures, and we will coagulate those and keep those from bleeding or reforming a clot that then can turn into bone again.
Dr. Hanel performs at least one stiff elbow operation a week, sometimes 2 or 3.
We come into the front of the elbow, we protect the critical structures, we get underneath the muscles that make the elbow joint flex, and then we find the scar, and the scar bone and the scar capsule. We remove that, and the reason that it takes us particularly long is that as we come across over to this side, there's some very, very important nerves that account for and are responsible for making our fingers extend and our wrists come back. And so we have to protect those while digging out a piece of bone that is going across the elbow into the forearm.
Okay, Dr. Hanel. Oh, yeah. I have your images up.
I like it.
It's good. Good job.
Thank you very much.
And when the surgery was complete, the team carefully realigned Warren's tattoos, another of his preoperative concerns.
We can line up tattoos. In patients that don't have tattoos, we put a skin marker on it, and we put hash marks on that, so at the end of the procedure we can line up the hash marks. All we have to do with him is line up his tattoo.
More importantly, of course, Warren can bend his elbow again.
It's such a dramatic improvement over what it was. And any of it would have been an improvement, but it's beyond what I had hoped for.
In young people, broken bones may have serious consequences when a growth plate is involved. Growth plates are a more fragile area where, as the name suggests, bone is actually growing to its adult size. Lindsay Brown fell during a basketball game and broke the radius bone in her wrist. She was 12 years old, and that bone was still growing.
It happened when I was in 6th grade. I was playing basketball, and it was my first basketball game, so I was really excited. So when I got into the game, I tried to intercept a basketball from the opposing team, and I lost my balance as I was coming back down, and I used my hands to brace myself. And so my left hand was the only one that actually got hurt. My right one was fine.
The original fracture healed, but the stage was set for future problems.
Depending on the extent of the trauma and the pattern of the fracture, the growth plate may either continue to grow if it's properly aligned and everything and there wasn't a significant trauma, or it may actually stop growing. And one of those growth plates for the arm is located right at the wrist in a bone called the radius, and it's very prone to sustain injuries there with just a fall on an outstretched hand that we call it. And that's what happened.
Over the next year or so, one bone in Lindsay's wrist continued to grow while the other stopped.
Over time, because the one bone stopped growing, the other bone started jutting out, and it just got worse and worse. And as it increased in being misaligned, the pain increased.
Lindsay had developed a radius malunion in her wrist. That's when her doctor referred her to the University of Washington Medical Center.
When she came to see us, she had already developed a significant deformity of her wrist, and although she didn't have that much pain, in the future would have been a big concern for her, developing pain and arthritis.
Dr. Thomas Trumble discussed surgery with Lindsay and her parents.
Once someone has healed in a malunited position, as Lindsay did, it requires a fairly dramatic surgery to bring back her correct anatomy and restore her function.
He was pretty matter-of-fact about, this is probably going to require something. And then his physician's assistant, who is the lady that stayed with us through the whole process, he told her, he says, could you go get my book, please? And they went and got his textbook that he had written on this surgery, and they went to page something, 540 or whatever. Open up the page of the book, and there was the exact kind of surgery that he was going to perform. That was an immense amount of comfort.
Lindsay's surgery actually involves cutting or re-breaking her bone. This, of course, is done surgically under anesthesia. This re-breaking allows us to distract or pull her bones back out to length and readjust the shape and alignment. We replace the missing bone with new donor bone and give her the time and support she needs to grow her own bone into the donor bone. It's a lot like Ivy creeping onto a lattice work. Her own bone grows in, replaces the donor bone, and ultimately it all becomes Lindsay's bone. And this is supported by using a special metal plate. Lindsay only needs this plate for as long as it takes her bone to grow in.
The plate is sort of splinting that bone, just like a cast would do, but right on the bone and stronger than cast because it's metal. And if you look from the side, this long white line here, this is metal from the plate, so you only see the plate in profile, and you see all the screws now that go from the underside of the wrist to the opposite side of the wrist. Multiple screws here and multiple screws near the joint surface. Now when you look on the view like this, you only see the head of the screw, but you see the plate now head on.
While Lindsay had outpatient surgery, her dad sat patiently in the waiting room.
There must have been 3 or 4 other complex hand surgeries being done, which was quite amazing to me because I was talking to some of the patients, or the relatives of the patients, and the things that were being done just amazed me at how they could reconstruct and redevelop somebody's hands and joints in day surgery.
I'm just happy that I got a doctor that really knew what he was doing before the surgery. He kept reassuring me that it'd be okay, and because I was really scared about going under, not being completely knocked out because I didn't know what was going to happen. I didn't know if I'd wake up again, and so I'm just happy he really reassured me and made sure everything would be okay.
All right, cast yourself, set to your partner.
Lindsay healed in time for volleyball season, about 6 months after surgery. She's no longer playing through the pain.
Yeah, it's gone. No pain. I just tape up when I play sports and it's fine.
She's gone back to a very, very high level of play, and that's what we were hoping for, and that's what she's achieved.
So what we're planning to do is we'll make a little incision there after they numb up your whole arm, and with the scope, look on the underside there, and then be able to divide the ligament that's pushing on the nerve, so take the pressure off the nerve. We'll then stitch it up, put a bandage on, you go home, take the bandage off tomorrow, put a Band-Aid on.
Sounds good to me.
Sharon Bossy has carpal tunnel syndrome. She's depending on surgery to make her right hand useful again.
It's a constellation of symptoms that patients get that usually is predominantly numbness and tingling in the fingers, and it's mostly the thumb, index, and middle finger. It often is associated with people who do a lot of things with their hands, repetitive activities.
It's just like if you were to sleep on your arm or something and you wake up and it's kind of tingling and you just shake your hand a little bit or something like that. It's like that all the time.
It doesn't hurt, but Sharon can't trust her hand. She can't feel how much pressure she's using on a keyboard, can't tell if her grip is strong enough to hold a cup, and can't feel the clasp to fasten a necklace. The problem developed over a couple of years, but it came to a crisis point when Sharon became involved in helping some African villagers.
What really set her over the edge was she was doing some missionary work in Uganda and was peeling hundreds of potatoes, and that really made it quite a bit worse.
That was tough, and then I knew that things were really getting pretty bad, and I knew when I got back to the States that I was going to have to do something to make things better.
Are you comfortable?
Carpal tunnel surgery is probably the most common operation in America, and it's performed often at Harborview. But before surgery, Dr. Vedder and the other team doctors recommend trying more conservative treatment.
Now, if you buy one of these over the counter, if this starts to wear out a little bit, the angle here is a little bit too severe, so you can either adjust it or have someone adjust it for you.
Wearing a splint at night so that you don't do this, and sometimes that helps enough to get people over the hump so that they can go about their business and it doesn't bother them. When that fails, though, the next step is to usually investigate and determine exactly what the problem is, and that usually involves doing electrical studies of the hand and the arm that can show that there is a slowing of the electrical electrical conduction of the nerve at the wrist. And if it shows that, and they failed the conservative treatment, then we usually recommend that they have surgery.
Surgery for carpal tunnel syndrome used to be pretty extensive, often with a fairly long recovery time. That's not the case anymore.
The newest development has been towards doing it through smaller and smaller incisions. The biggest development has been the introduction of the endoscopic technique. It has a little camera lens at the end, and the blade comes up so it can work from underneath. The endoscope uses a small scope that can be put in through a very small incision, and through that scope you can see the ligament that you need to divide, and that's the essence of the surgery, is dividing that transverse carpal ligament that forms the roof of the carpal tunnel. And there we got a nice view of the underside of the transverse carpal ligament. So here comes the blade. So by dividing that ligament, you open up the tunnel and take the pressure off the nerve. Here's the distal edge, so we can see that it's completely divided.
The endoscopic technique pays off in a shorter recovery for patients after surgery.
There we go. And that's it. My partner, Dr. Trumble, did a large study here comparing the open technique with the endoscopic technique, and found that patients who had the endoscopic technique recovered much faster, had a lot less scar tenderness, and were able to return to work much faster. Looks good. Can you wiggle your fingers?
Oh, yeah.
Great. And touch them all?
Mm-hmm.
Very good. We're able to do the whole spectrum of hand surgery. And because we have different people from different specialties, different backgrounds, who all work together very well, it's a unique opportunity for patients. It's a unique opportunity for training the next generation of physicians for the Northwest. It really works out well.
One of the core aspects of what our hand and microsurgery team offers patients is complete, comprehensive care. For our team, it doesn't matter what type of problem you have or how severe it is. We always have a team on call. This is on a 24/7 basis to provide care at the University of Washington Medical Center, Harborview Medical Center, Children's Hospital Medical Center, and the Veterans Hospital and Medical Center. Our surgeons can mobilize to quickly reattach a severed hand or repair a fracture from a child who fell on a playground.
So tell me what you know about arthritis. Not much.
One of the most common problems that the UW Medicine doctors see is arthritis, especially thumb arthritis.
Thumb arthritis is a combination of hereditary factors and gender. You may have inherited your arthritis from mom or dad. Women suffer from thumb arthritis up to 8 times more often than men. The arthritis can affect both the dominant hand as well as the non-dominant hand. This means that people often present with both thumbs in pain, making it impossible to do even simple chores.
So this is going to be warm.
As with carpal tunnel syndrome, the team considers more than one type of treatment rather than trying surgery immediately.
Often the patient's own family physician can provide the initial treatment, either through therapy, braces, or medication. Even simple over-the-counter, non-steroidal anti-inflammatory medications can help a great deal. In the more advanced stages, we'll offer steroid injections. When conservative treatment doesn't relieve the pain, there's still the option for joint replacement surgery.
Let's go this way. 4.
Linda Holland was ready for surgery. Her left thumb was useless because of the pain.
You can't imagine the things you can't do without a thumb. And, I mean, you can't do this. You can't hold on to things. You can't pick things up with your left hand if you don't have a thumb. When you're cooking, and I do a lot of cooking, I couldn't actually get a grip on the bowl to do the beating and the whipping and things like that.
As in Lindsay's case, Linda's doctor referred her to Dr. Thomas Trumble.
And Dr. Trumble, the miracle worker that he is, he looked at that, he looked at the x-rays, and he looked at my thumb, and he said, we can fix that.
This is the joint that has the most severe arthritis. Now we need to clean the tissues around this, and then we'll start to trim the capsule from around this joint.
Surgical treatment for arthritis involves removing the painful contact where cartilage has worn away and bone surfaces rub against each other.
In order to accomplish the surgery and to relieve the pain, portions of the arthritic bone are removed.
So now we've removed the arthritic bone there.
And one of the key aspects of the surgery is to use a biological spacer, such as a cartilage graft.
This is what the cartilage block looks like. It was actually from a rib.
This is a donor graft that's been completely screened to be free of any diseases. The graft provides a cushioning surface between the two painful bone ends.
Grass sinks nicely.
However, sometimes artificial materials are better suited to a particular patient.
Our research programs for the hand and microsurgery team are constantly looking at new techniques to improve the care for our patients. There are new devices that we've worked on to develop for arthritis that have smoother surfaces with lower coefficients of friction. That means that they cause less wear and tear over the person's lifespan. Our research has also improved the treatment of fractures, tendon injuries, and nerve paralysis.
You can see this little scar right here. He opened it up there and he opened it up there. He replaced this joint, and I think it's a titanium maybe, and then it has Teflon in between the joints here to stop the bone from rubbing together. Then he took a piece of tendon from back here where you have a ton of it and you don't need it all. He took a piece of that and he pulled it loose and thread it back through the carpals and got this joint, and then he went on up into this one and he used two little, they look like little stars in the x-rays. There's actually 3 of them that hold the tendon and the joints in place. And now I have a thumb. See, I can use both hands. Isn't that fantastic?
Linda won't have to have her implants removed. The materials that were used will become a permanent part of her hand. It speeds recovery and makes her life a little easier.
There's no need to provide a secondary surgery to remove implants, such as done in many other types of surgery. This helps to prevent problems with infection, it relieves pain, and it makes their treatment overall much simpler.
Buzzy, come here.
Linda and her husband Joe live far across the state from Seattle and the University of Washington Medical Center. It's a long trip when she needs to see her doctor.
It takes me between 9 and 10 hours, depending on if we stop and go in and eat somewhere, and how many times we have to walk the dogs. But I can't imagine going anywhere else. All of the people that are involved with the operation, the technicians, the nurses, the other doctors, everyone was so conscious of my needs and how I was feeling.
The key is to not just treat each person with the same cookie cutter procedure, but to really match up the procedure that truly meets their needs and their demands and their anatomy, so that we get the best long-term lifespan for their treatment.
I just can't even imagine being anywhere else and having that kind of care. Never received it before, ever.